So what do we do after first line treatment? Of course, we go through all of these before we start any treatment. But here I would say on second line, the most important features are the tumor molecular characteristics that one would decide the further continuum of care. And of course, patient is the most important for us. So patient preferences, patient clinical characteristics. And here, right and left on all those things may not be of a major benefit to us. Of course, but the tumor burden symptoms are all very important for us. So the plan that we usually follow after first line treatment, generally, at least in practice, what we follow is A plus B, that is one line of treatment. So we go to another non-cross resistant type of a treatment, sequential approach, or we continue the first line of treatment, which is going on, and just change the backbone of the treatment, or the chemotherapy backbone or the biological arm. Or the third thing which I'll be discussing is this switching back to the alternative therapy. So let us see now what happens in the second line in those patients who are biologically naive, those patients who enter the second line treatment after only chemotherapy. And here, obviously, our talk is on EGFR, so I'll be saying only on the EGFR. So this was a large EPIC trial published way back in 2014. It was an open label randomized, very rarely you see in colorectal phase 3 large studies. That's why I've kept up this study. It was a large study where patients who were, mind you, see this, it was an EGFR expressing metastatic colorectal cancer after failure of oxaliplatin, and they were randomized as we would do in practice, cetuximab plus irinotecan. Of course, nowadays we use more of oil-free or single agent irinotecan. The primary endpoint was overall survival, and the secondary endpoints were PFS, response, safety, and so forth. So more than 600 patients in each arm. And here we can clearly see that cetuximab plus irinotecan, after failure of FOLFOX in first line, in those who did not receive cetuximab in first line and they received in the second line, the response rate jumped up by four times more. If you see 4.2 versus 16, the PFS was also better, but overall survival, the median overall survival was not better because 46.9 or 47% of the patient in the irinotecan arm crossed over to cetuximab arm, which impacts the overall survival. Now, if you see what happens in exon 2 wild type only, in exon 2 wild type, if you see here, the response rates were still better. The PFS was also better. Here you can see a hazard ratio of 0.77. The overall survival, again, the explanation being same, that is the crossover from irinotecan arm to cetuximab. So overall survival benefit could not be seen. Now let us see in all RAS wild type. Here, if you can see the overall response rates by adding just cetuximab to irinotecan jumped up by more than 6 times, from 5% to 20 to approximately 30%. The PFS was also hazard ratio of 0.7, where we earlier saw it was 0.57, where earlier we saw it was 0.7, with only exon 2 wild type. And again, overall survival no benefit because 47% of the patients switched over to cetuximab arm from irinotecan. Again, now let us see if when these patients who received cetuximab plus irinotecan relapse, what to do. If there was no subsequent therapy, the survival was only 3.9 months, but continuing cetuximab and another arm of therapy, the overall survival was 19.1 months, and without cetuximab, it was just 9.5 months. So continuing cetuximab showed better results than just continuing either chemotherapy alone without cetuximab or no therapy. Obviously, one would not be doing unless the patient's condition is very poor. So this study concluded that cetuximab plus irinotecan improved the PFS response rates with a good quality of life versus giving irinotecan alone. So giving cetuximab plus irinotecan was better, and it supports that second line cetuximab plus irinotecan used after first line chemotherapy in RAS wild type who missed the chance to receive first cetuximab in first line setting. Now let us see in those patients who have received earlier EGFR plus chemotherapy, what are the studies in that? So here, this was one of the large Capricorn study where cetuximab plus FOLFIRI, where cetuximab plus FOLFIRI was given in the first line exon 2 wild type, and when they develop a progressive disease, they were randomized to continuing cetuximab and changing the arm of the therapy to FOLFOX, or giving only FOLFOX and till progressive disease or toxicity. And they saw the primary endpoint was PFS2. Here also it clearly showed that in the RAS wild type, of course, the PFS was modest, hazard ratio was 0.8 when cetuximab was continued with FOLFOX or continued FOLFOX. But when this turned out to, when they did a subgroup analysis of RAS, BRAF, and PIK3 mutation, they saw that the PFS was much better when cetuximab plus FOLFOX was given. So RAS wild type, BRAF wild type, and PIK3, they selected the patient. In that way, the PFS2 was much better and the hazard ratio was 0.56. So the conclusion of this study was that given the median PFS of 11.1 months and the median overall survival of 21 months attained in this study, the median overall survival, if you start cetuximab as a first-line therapy and continue, the overall survival could go up to 30 months in a RAS wild-type metastatic colorectal cancer. So here in the triple negative, what we say, they're all wild-type, there was a trend towards improvement in overall survival when cetuximab was continued with FOLFOX. This is a small Chinese study. We can skip this and we'll go to this coming to maintenance of cetuximab. So this was again a macro 2 study. It was a phase 2 study, and in untreated KRAS wild type metastatic colorectal cancer, 193 patients, cetuximab plus FOLFOX and given 8 cycles, and cetuximab alone was continued, or cetuximab plus FOLFOX was given and treatment continued till progressive disease or early withdrawal. So this was a maintenance therapy, and the primary endpoint was PFS at 9 months. Again, it showed that there was no major difference in the PFS at 9 months. It was a non-inferiority treatment, but those in whom FOLFOX plus cetuximab continued was a valuable option compared with mFOLFOX, but compared with modified FOLFOX cetuximab continuing treatment. So it was a non-inferiority study where they showed that basically cetuximab plus maintenance, cetuximab as maintenance was equivalent to cetuximab plus FOLFOX. So why to give the patient the side effects of FOLFOX? So cetuximab maintenance was non-inferior and continuing FOLFOX with cetuximab. This was again an unusual study, again a phase 2 study where previously untreated RAS or BRAF wild type metastatic colorectal patient, number of patients was just 143. But what was important in this study that contained FOLFOXIRI in a modified manner. And when they use this study and cetuximab plus FOLFOXIRI 8 cycles or cetuximab plus FOLFOXIRI 8 cycles, and upfront patients were randomized after completion of 8 cycles to either continue cetuximab as maintenance or bevacizumab as maintenance. And the primary endpoint was 10 months PFS. Again, in this study, neither of the arms was superior to one another, but an exploratory analysis of this showed that the 4 months only of a modified induction FOLFOXIRI got much better results surgically. There was a high surgical resection rate. That was the backbone of this study. Coming to now panitumumab maintenance regimens. Now, how do we give panitumumab as a maintenance? We saw that in cetuximab, giving cetuximab single agent maintenance was good enough. Then giving cetuximab plus chemotherapy, it was non-inferior. We saw that in a phase 2 study. Now we are in the Valentino study, again another phase 2 study, unresectable, untreated RAS wild type metastatic colorectal cancer with no prior oxaliplatin received FOLFOX plus panitumumab or FOLFOX plus panitumumab up to 8 cycles, and then maintenance with 5-FU calcium panitumumab or panitumumab alone. So whether panitumumab alone could withstand the benefit of giving alone or 5-FU with leucovorin has to be given. But here in this, I'll just go to the conclusion of this studies that in this group of patients, it showed that in RAS wild type metastatic colorectal cancer, maintenance therapy with single agent panitumumab was inferior in terms of PFS. As you can see, the PFS 12 versus 9.9 months. So if we have to use panitumumab as a maintenance, panitumumab plus 5-FU calcium leucovorin with a slightly increased risk of toxicity. So panitumumab plus 5-FU leucovorin appears a suitable maintenance option rather than containing single agent panitumumab. Similarly, this was a Sapphire study. Very similar things. We can see that panitumumab plus FOLFOX in the first, followed by FOLFOX plus panitumumab, or just give 5-FU leucovorin with panitumumab until this progression. And here we could clearly see that discontinuing oxaliplatin was non-inferior. So if we could uh, release out oxaliplatin and continue with only 5-fluorouracil with panitumumab, the results were quite similar. Now coming to one of the latest studies, the ASCO 2021, this was presented, and this is from EIO KRK 0212 group. This is a slightly complicated study. If you can see, this is a study of panitumumab, where patients with RAS wild type metastatic colorectal cancer with good performance status received, have priorly untreated, had received FOLFOX with panitumumab 6 cycles, and those who showed a complete response, a partial response, or a stable disease were randomized to 5-fluorouracil panitumumab or only 5-fluorouracil without panitumumab till progressive disease. And once they developed again a recurrence, this was, sorry, once they develop a recurrence, they were again put on FOLFOX plus panitumumab, or means in both the arms, either FOLFOX and with panitumumab was given in both the arms. Here we can clearly see that whenever 5-flu plus calcium-leucovorin with panitumumab as a maintenance therapy was superior to only 5-fluorouracil as far as the PFS is concerned. Of course, the overall survival data has not matured, but continuing panitumumab with 5-flu plus calcium-leucovorin rather than 5-fluorouracil alone, there was a significant improvement in PFS. But now let us see what happens here when either of these arms develop a progressive disease, whether when we are giving 5-fluorouracil and panitumumab or 5-fluorouracil and they develop progressive disease, do we reintroduce panitumumab FOLFOX? No, that was not a positive arm. That arm showed that there was modest results. If you can see here, that those patients who had received 5-flu plus leucovorin plus panitumumab and on recurrence, they received FOLFOX with panitumumab, the PFS was just 3.3. Of course, because these patients had not received 5-fluorouracil, they were slightly better. So let us go to the conclusions of this study, that panitumumab is active as maintenance, as the previous trials also showed, in combination with 5-fluorouracil. So with the chemotherapy, panitumumab works better, and 5-flu plus panitumumab should be regarded as preferred option of maintenance therapy following FOLFOX plus panitumumab in patients with RAS wild type. And of course, when we try to re-challenge with FOLFOX plus panitumumab, the results are not good. So it is better that we continue 5-fluorouracil and panitumumab rather than just giving them 5-fluorouracil. So is there any role of anti-EGFR in re-challenge setting? So the basic model of the concept of, is this, that it's very simple, that cetuximab plus FOLFI, and we give what happens here. You can see the cetuximab sensitive clone declines, and slowly the resistant clone becomes more evident, and that is the time we see resistance to cetuximab. So just withhold cetuximab, that is the basic concept, and wait till the sensitive clones pick up, and then re-challenge with cetuximab. That is the basic concept here. And here we can see the ESMO guidelines here, which showed that re-challenging, if it was a RAS wild type, and our aim is tumor shrinkage, then to give EGFR-based treatment, cetuximab plus chemotherapy or single agent, as we saw in the EPIC trial. Second choice was EGFR antibody monotherapy, and this is of course in RAS wild type. And third choice, they said, was regorafenib or TAS-102. Of course, in RAS mutant, we don't think of cetuximab, and hence regorafenib and TAS-102, or BRAF mutant also, we would use this. And when there is our aim is just progress controlling the disease, you can see the ESMO guidelines says the same thing. It's all very similar. And the basis of this ESMO guidelines is the Cricket trial, which was a phase 2 multi-center single-arm study, where you can see RAS or BRAF wild type use cetuximab plus FOLFI or FOLFOXIRI. In second line, they use bevacizumab so that the sensitive clones of cetuximab picks up. And then they did again a liquid biopsy to see that the RAS wild type clone is still there. And then they re-challenge with cetuximab plus irinotecan. And here you can see there was a gross improvement if the patient had wild type 4 months versus 1.9 months in the third line. So was the overall survival benefit, hazard ratio of 0.58. Of course, these are all phase 2 studies. And this is on the basis of which you can see the comparative arms, the overall response rate. If the RAS wild type persists, overall response rates are 21.4% in the RAS wild type. Whereas if you see the phase 2 RAS wild type, it was just 1 and 4. So this was quite superior when RAS all RAS wild type clone persists, the overall response rate, PFS, and the OS were much better in the third line. And when you re-challenge it with a short gap of cetuximab. So ESMO guidelines supports the concept of re-challenge with the therapy used previously in first-line treatment. This is a large phase 3 study, the FIRE4 study, basically very similar, cetuximab plus fall-free. And when there is a recurrence, just use bevacizumab plus fall-free, again randomized to this. And the important part of the study that the primary endpoint is overall survival after second randomization. That is after the third line, there is an important, whether there is an improvement in overall survival. So the results of this study will tell us, is there really an improvement in overall survival also in the third line? So let us come to the conclusions of my talk. So in EGFR neo patients, we saw the EPIC study of a large phase 3 randomized study. After FOLFOX, when there is a disease progression in RAS wild type, cetuximab plus irinotecan improve the PFS and response rate with a good quality of life. Now coming to maintenance cetuximab, we know cetuximab on progression while changing the chemotherapy arm to a non-cross resistant arm is a promising approach, especially in a molecularly selected patient of metastatic colorectal cancer. We saw triple negative, that is all RAS, PIK3, and BRAF negative. In the Capricorn study, there was an improvement. And when we use FOLFOXIRI plus cetuximab as a maintenance and continue cetuximab or bevacizumab maintenance, there is no major difference. There was no major benefit of either cetuximab or bevacizumab, but high surgical resection rates were possible. Panitumab when used as maintenance give good results when we continue the chemotherapy backbone to be continued of 5-fluorouracil. The results were quite good. And there is now a good biological rationale, that is by complementary, by doing a test with wild type RAS and seeing at the time of re-challenge, if the clone is of wild type RAS still persisting, we can re-challenge the patient with cetuximab in the third line would be a useful option. Thank you very much, and I hope I've finished in time.